Welcome back to the Better Health Now podcast. Today I have the opportunity to have a familiar face back on the podcast. For those that maybe haven't seen your first episode, would you like to introduce yourself and tell us about your journey to get here to Coleman?
Absolutely. I'm Dr. Bitterly. I work for the hospital. We're based out of Surgical Arts, and that's a hospital-based group. So my background story is pretty extensive, but where short version is ex-military, traveled everywhere around the world, ended up having kids and settling down in a small town for our big adventure. And it has been an adventure, and we love it here. So
Awesome. So today we're talking a little bit about some of the surgeries that you perform on a regular basis. Primarily, we're talking about hemorrhoids and hernias. Why do you think that these are important health topics? And is there an age group that should really be paying attention to this?
I think it's really all age groups, to be honest, because hernias, there's different types of hernias, and every hernia type, some are related to incisions and surgery. Some of them are just congenital and occur in, young age groups are pretty common. And then there's also a kind of bimodal distribution in older ages where they start just noticing when skin gets lax and loose or the tissues get loose. And then these hernias kind of just pop up. Hemorrhoids is everybody. American diets are terrible, and we don't eat enough fiber in our diet, and tend to do a lot of interesting things in the toilet, like Facebooking and such, which we can get into that in a minute. But a lot of women specifically older women tend not to talk about this topic. I think the younger generations are more comfortable with these issues, but the older population is very uncomfortable. You just didn't talk about it. And I think there's a lot of people out there that can benefit from some of the things that we'll talk about today.
Yeah. And so kind of jumping into the topic of hernias first, how do you go about diagnosing a hernia, and what tests are maybe involved with that process?
Yeah. Hernias can pop up at any time. There are the three main ones that we mostly deal with. Now, the hernias, you can hear about hiatal hernias, you can hear about diaphragmatic hernias. All those things are very specific, and they're inside the abdomen. You don't necessarily see any of those. But the ones that people tend to see are the ones that pop up on the belly. So you're looking at umbilical hernias. Umbilical means your belly button. So that's an area of weakness. Anytime you have an area of weakness, you can develop a hernia. The groin, inguinal hernias, those are very common in men. That's probably the most common. And then we call incisional hernias, where after you've had a surgery, people have laparoscopic surgeries or have big incisions from trauma or just previous surgeries, gallbladder surgeries, etc. And that area is an area of weakness. A hernia, by definition, is just basically a hole or a defect. So a little bit of background anatomy. You have different layers of the abdomen. So the inside, where all your guts are, there's a thin layer called the peritoneum. And then on top of that, you have some fat. And then on top of that, you have this tough stuff, the stuff that keeps everything in, called the fascia. And that is the key player here. The fascia, once you get a hole or a defect, that is technically a hernia. Now, whether anything is coming out of that hole is what people see. And so most people will come and they'll say, hey, their story is, I was just in the shower and I noticed this bump in my groin, or I just noticed this bump in my belly button and I pushed it and it went back in. And, what is that? There's an alien, there's all these interesting stories. Older people would tend to have painless hernias where it's a bump that gets bigger and bigger and bigger. And they finally come in to talk about it. In the military, we had the story was a lot of young guys doing huge 300-pound weightlifting and getting ready for their PT training or, AFSOC or whatever the special trainees were, Marines, and they'd be lifting, and then all of a sudden they would feel a sharp pain either in their belly button or in their groin, and they would see a bulge, and they couldn't get that bulge to go back down and ended up in the emergency room. Okay, so all of those, it's very benign, very non-scary stuff, all the way to very painful experiences that lead people to get evaluated for hernias.
Yeah. And so with that, if they've had like a gallbladder surgery or they've had some kind of surgery, is there a window of where that skin or where the area could be more acceptable or could potentially lead to a hernia Uh, And is it something that is just like forever, or is there just a kind of that window of the highest opportunity?
Sure. So if any of you have had surgery, your surgeon or your discharge instructions will usually say no heavy lifting after surgery. And people, they have their 50-pound dogs or their, 50-pound kid
I
that
didn't
comes
go to the
across.
gym,
I need to
just
go to the
picked up my
yeah,
dog
right,
or whatever.
exactly. And so, most of these surgeries are now done laparoscopically, but anywhere where during that time period, it's about 4 to 6 weeks that it takes for that fascia, the tough stuff we talked about, for it to heal completely. Now, it never actually heals completely. It only goes to about 80% of what we call the tensile strength, the strength of the fascia. It only goes to 80%. It'll never get to 100%. But during that window, it's less than that.
Wow.
So, the old school surgeons used to say 6 weeks. We now say 4 weeks, more so now, because they don't think that there's really a big difference there. Um, but I'll be honest, if I get a young military guy who's pumping, I
Yeah.
don't trust him to run 10 miles or pump 300
Yes.
pounds. I'll just tell him, well, you're going to wait the full 6
Yeah,
weeks.
probably 6 weeks.
So that makes me sleep better. I don't know if that actually does anything for the patient, but that's usually the window in which we try to have patients restrict or restrain themselves from, lifting weights, lifting things,
Mm,
doing squats, doing chin-ups, anything that makes your intra-abdominal pressure go up. We try to reduce that. Pilates,
mm.
planks, things like that where you're really using your core.
Yeah, and so not all hernias require surgery. It just kind of just depends on the level, typically. Talk a little bit about some of the treatment processes for hernias, especially if you have someone that comes in early in their symptoms rather than someone that waits till it's too late.
Gotcha. For umbilical hernias, the one on the belly button, those tend to be congenital because we all have a umbilical cord when we're babies, and that hole after the umbilical cord falls off as a baby, it's supposed to close up, and sometimes it doesn't. And over time, weight gain, hormones, age, all of those things can contribute to exercise. Aggressive exercise can contribute to the stretching of that hole that may or may not still be there. Um, for those particular hernias, I usually recommend that you get the umbilical ones that get them fixed because those can get larger and it's sitting right here where you can end up getting intestine caught into it. So, any hernia that has intestine in it, I highly recommend that you get it fixed or at least get evaluated to discuss getting it fixed because
Mhm.
what we try to avoid as surgeons is we try to avoid you being in an emergent situation.
Mm.
Okay. If you have fat in your hernia and there's not intestine in it, um, you know, we don't jump the gun and highly recommend that you get it fixed right away, but we don't want it to progress to where bowel is in it. If bowel is in it and you're a good surgical candidate, then we try to do that electively. And there's always a better outcome with people if you do an elective surgery versus waiting until you're in an emergent
Mm.
situation. The intestines can come out into those hernia sacs, and it's just like have you ever seen the jar with the raccoon and the fist trick
Mm.
where you put like a shiny
Yeah.
object and you catch the raccoon by putting the fist in there? All they had to do is let go and their hand can come out. That's sort of the same idea. If the hernia is the hole at the top of the jar and the raccoon's hand is the intestines, it can come out into the external component, which is, the skin, you can see it, and then it makes a fist because it gets constricted. There's blood vessels
Mm.
that flow, and so it gets swollen and inflamed. That's the body's response to lack of blood flow, and it just makes it worse. It becomes a vicious cycle to a point where it can't come back into the hole. And then you're dealing with the medical emergency where the intestines would have to be cut and put back together, etc. So we try to avoid that situation.
So with some of the surgeries, and you alluded to this a second ago, but can hernia surgeries being used minimally invasive techniques? If so, why is that better for the patient? Is it a patient basis that what kind of surgery is best fit, or do y'all typically try and do a minimally invasive surgery all the time?
So, one, we try to avoid emergent surgeries because usually, if you're in an emergent surgery, most hernias are going to be better repaired and more sustainable long term with the mesh. Now, this varies based on the size, and there's different sizes give different recommendations based on the literature. But in general, groin hernias and umbilical hernias, you usually want to place a mesh in the appropriate setting because in the long term, that mesh will help the body scar in. It's kind of like a scaffolding system, basically, or kind of like imagine concrete and rebar.
Okay.
The mesh serves sort of as that rebar, and the concrete is what your body does um, to scar in. Okay. Now, people usually ask a lot of questions about like, well, is this one of the meshes
Yeah.
that are on the market that have been pulled? Most of the time, hospitals have reviewed those things,
Yeah.
and the second any of that happens, those things are pulled from the market. The meshes that we have now have been pretty tested for many years, and most of them tend to dissolve. They just dissolve slowly so that the body can replace the the rebar that's in there over time and
Yeah.
scar well. So that's number one. Number two, we tend to do these things elective, and most of the time when they're elective, we will try to do them laparoscopically, which is minimally invasive. The other option is robot. That's, also minimally invasive. Most patients don't know the difference because all they see are the little poke holes. But as far as recovery, laparoscopic surgery usually allows patients to recover a little bit sooner. The
Okay.
bigger the incision, the longer it takes to heal. There are still cases, though, where we will do open procedures. I will still do open inguinal hernia repairs or umbilical hernia repairs, or not umbilical. Usually it's incisional by that time. But sometimes it's umbilical,
Wow.
That's just a semantics kind of thing. But basically any of them that are in the front of the belly, sometimes we still have to do them open, based on the size, the amount of surgery the patient has had. There's lots of things that go into play. How big the hernia is. Larger hernias are hard to repair laparoscopically or robotically.
Yeah.
So
And so before we kind of transition the conversation into talking
sure.
about hemorrhoids, is there anything else that you want people to get or understand or know about hernias before we transition topics?
I think in general, the big things to remember are if you see a bump and it's new, if it's painful or it's getting larger, or if you're having symptoms of constipation and you notice this, or swelling or bloating, those are all with a bump associated. Those are all indications to possibly go see a surgeon or at least to go see your doctor. Most of the time, your regular doctor will be able to identify those things. They may or may not order imaging, such as an ultrasound or a CT scan, and then get you referred to a surgeon to be evaluated to discuss whether you do need surgery or not in that case.
Yeah. And so, kind of moving into the topic of hemorrhoids, do you find that patients are hesitant to talk about hemorrhoid symptoms or even not seek treatment because it can be embarrassing or uncomfortable for the discussions?
Absolutely. You hesitated in just
Yeah.
saying that.
No, yeah. It's hard enough just to even talk about it on our end. So, like,
Absolutely.
having that patient understand, and hopefully, this conversation helps these patients know that it's okay to talk about
Right.
it's stuff that happens, and we need to make sure that we're able to treat it appropriately.
Right, exactly. Yeah, hemorrhoids, everybody knows somebody, whether they know it or not, that is suffering from those things. Most of the time, the ones that I see, and it's probably just because I'm a female, I get a lot of females who come in who address that issue, and they've had this for years, and they haven't really discussed the basics of just hemorrhoids. And a lot of things that people don't understand is that hemorrhoids are the original swellings are called Cushing's, and they're actually tissues with blood inside of them, and they're supposed to be there. They're supposed to be there to sense the stool as it comes down, and it's a very amazing. I know the anus being amazing, but it is an amazing complex process for you to have a bowel movement. And so those little Cushings are supposed to be there to let you know, hey, there's a stool coming, and you need to either tighten it up and run to the bathroom, or you're sitting on the pot and time to relax.
Yeah.
And so it gives you the urge. The problem is that a lot of times because of constipation, number one, but also people don't think about diarrhea. Anything irritating those sacs of blood can cause them to swell and get larger and drop down, and that's what contributes to the development of hemorrhoids. It's overactive Cushing's, basically sacs of
Okay.
blood. The good news is that you can do things just behaviorally to reduce that. The bad news is that if you don't fix the problem, you can cut these out as many times as you want, and they will come back.
Wow. And so, like, what other, I mean, kind of leading into the conversation of talking about just the impact it could have on a patient's health.
Oh yeah.
Talk a lot about, what it can effect for the patient if it's left unattended,
Mhm.
and sort of that journey for the patient to coming in to then getting their hemorrhoids treated.
Yeah, a lot of women will have developed these after pregnancy is the most common thing you hear. It's one of the burdens of children. You know, but I won't go into that. But basically, you have a increase in pressure. Gravity works, and so you have a big baby that's there pushing down. You're sitting, and it's causing pressure, and so that's what causes those cushions to kind of drop down. Other things that men don't really talk about, and they tend to do this a lot, is they like to, because they're constipated or they feel an urge, they like to sit there. And, the old thing where you used to put magazines on the side of the toilet. Now it's Facebook and people are scrolling and all of those things. Terrible, terrible for your hemorrhoids. If you imagine gravity works and you've got a toilet, which is a hole, you've got the anus, and you're sitting and you're just pulling. It's just gravity's pulling, and blood is going to go to the dependent area. It's going to go down. So it worsens the hemorrhoids to sit on the toilet for more than 10 or 15 minutes. You should not. You should go in, take care of your business, and get out.
Oh, wow.
So that's number one. Number two, if you're having any type of straining, well, people don't really like to talk about it, but some people will splint where they have to stretch their buttocks to get things to come out, and up to a point where, and I know this is kind of gross, but some people have to actually help themselves, digitally help themselves or give enemas or things of that nature to help stool and things to come out. If you're having any of those things, those all contribute to the development of hemorrhoids. And the solution to all of that is to increase your fiber and water in your diet. About 90% of all anal disease can be fixed with fiber and water therapy.
Wow.
So,
And so is if a patient comes in and they're able to, they've seen this being issue and they've caught it early, what is sort of that process of treating it? What is the recommendation that you typically give to the patient, and when is that pain relieved?
Gotcha. So a little bit more on pain. So there's different types of hemorrhoids. There's internal ones, which are on the inside of the anus, and then there's external ones. The internal ones, there's no pain intervention, so you don't feel pain. They're normally your painless bleeders. So
are those more common, or is
they're about the same, okay, but people have different symptoms because, people will say, well, I sit on the toilet, I wipe and there's blood on my toilet paper, or I get drops of blood in the toilet. And if you don't know this, it only takes a couple of drops to turn your entire toilet pink but red. So it's a very scary thing when it happens. But if you have any bright red blood per rectum, it's recommended that you go see your surgeon anyways, or your doctor anyways, because it may be hemorrhoids, but there could be other more nefarious things. If you're over the right age, it could be a cancer or something like that. Most of the time, though, people know that they have hemorrhoids and go in and get checked for that. But internal hemorrhoids cause that. The external hemorrhoids tend to be your kind of itchy, painful ones. They don't usually cause sharp pain unless they are thrombosed. So the ones that all of a sudden you get a big purple bulge and that is tender to touch. That you need to go and seek medical care, because sometimes you can get some benefit cutting it open and relieving some of the pressure in the short term. But most of the time when they're not active, they're usually just irritating and itching, and kind of it makes you feel uncomfortable, like you have to constantly go to the bathroom. But the treatment for that, like I said, I recommend people, they usually come and see me when they're having these issues, usually for bright red blood per rectum, because they've never seen blood on the toilet paper before, and it's a scary thing. So we usually will do an anal exam and take a look on the outside. If they're the right age or have other symptoms, we will recommend doing a colonoscopy to make sure there's no more nefarious things going on, and rule all that out. And then I recommend usually 6-week trial of fiber and water therapy, because, like I said, if you can get the consistency of the stool, and we're going to use food references. No, everybody hates it, but I always say I want a bread pudding consistency stool. Okay, so everybody out there who loves bread pudding, I'm sorry. You'll never eat it again. But I think that's the big thing, is getting both for constipation and for diarrhea. So fiber, and I usually recommend either Metamucil or Benefiber. And no, I don't have stock in those. I also don't have stock in Fiber One. They're a great brand. But you can take that daily and make sure you're getting your 64 ounces of water. That's a hard thing. So it's 64 ounces of water, and the American Family Physician says 20 to 25 grams of fiber. I push that to 30 to 35 grams because most people don't actually make that number, but they shoot for it. Yeah. It's better. And so if you can have that fiber and drink the water, 90% of the people who come back actually have resolution of
Mm.
their symptoms, and they don't need a surgery. So, and surgery's great, except this particular surgery, if you have external hemorrhoids, you have to cut. And it is painful. Remember we talked about the sensation?
Yeah.
External, you can feel, and it feels like shards of glass on your anus for about 3 to 4 weeks.
Wow.
It's not-
Even post surgery.
Post surgery.
Wow.
Yeah.
And so is that recovery process after that 3 to 4 week period of those sharp pains? It's not comfortable.
It's
it's
not
not comfortable
comfortable.
to sit, not
Yep.
comfortable to stand,
Yep.
not comfortable to do anything.
Yep.
Is that when it starts to relieve, and sort of when does the patient see complete recovery and
Yeah.
no longer have any pain?
So usually after the 4 weeks, if I have to physically cut, it's usually after the 4 weeks. So 2 weeks is the worst. And so I don't schedule people for follow-up because they're cursing my name for like 2 weeks. You get some of those like outliers that do really, really well. And it's usually women, no offense, but they tend to tolerate this a little bit better. But you get some people who do well after 2 weeks, but, and people have to go back to work, unfortunately. So you have to figure out how to clean yourself at work. It's an uncomfortable process. And I do have some recommendations for that some people have done really well with, different things they can buy on Amazon to help with cleanliness at work. But really the recovery process, I say 3 to 4 weeks, and I have people follow up at that point. And we go from there. And the issue is if you're going to have surgery, I still make you do the fiber and water therapy because we want your stool soft. Because if you take pain pills, you're going to slow your bowels and you're going to end up with this process all over again. So it's a vicious cycle. So you have to so we do a lot of trial by fire, testing to make sure that the patients understand that they're doing good bowel habits, not sitting on the toilet for very long, that they understand what sitz baths are, either sitz baths or little irrigation systems you can buy and put in your toilet, bidets, or I usually just recommend getting in the tub during that time period, because the tub, you fill it up with this much warm water and you just sit. It kind of helps relax all the anal muscles. It helps everything go back to the way it should be, and it helps with pain control during all this process, and just during when people have episodes, when they're having episodes of hemorrhoid flares. I think sitz baths are fantastic.
Yeah, and it seems like this is something too that even the younger patients or younger people listening to this, something that they could, take away as something to not have this later on in life,
please.
is, have plenty of water, drink a lot of water, don't sit on the toilet for too long. The things that we've talked about are something that you can start doing if you're in your 20s or if you're in your 60s.
Yes.
And so being able to know that like there's no better time than today to get started.
Metamucil, you can buy the cheap stuff. I have Metamucil and I have Benefiber, fiber and water therapy. So, and you can sneak it in your spouse's coffee, the Benefiber, and they will never know.
There you go. Well, I appreciate you being here today. I think the two topics of hernias and hemorrhoids are topics that people, like you said, it's tough to discuss sometimes.
Yes.
But having conversations like this hopefully allow the people that are listening to know it's okay to come out, to meet with their physician and kind of get things checked up.
Absolutely.
But I appreciate you being here today. We'll be sure to have everything in the episode notes for links to anything that people might need.
Perfect.
But I appreciate you being here.
Absolutely. Well, thanks for inviting. It's been a pleasure.